Today we will discuss regarding PK-PD drug interaction. PK stands for pharmacokinetics, PD stands for pharmacodynamics, and drug interaction happens when two drugs are administered simultaneously. They interact with your system, and because of that, there may be some changes to the effect. That is why we call it as drug interaction. Now, what is pharmacokinetic? In broad terms, we will say that pharmacokinetics is regarding absorption, distribution, metabolism, and excretion of the drug. So, to summarize, we can say that these are the effects of the body on the drug, and pharmacodynamics is effect of the drug on the body. So, fate of the drug. Once the drug is administered, it will be absorbed, then it will reach the systemic circulation in the blood. From the blood, either it will be metabolized, it will be eliminated, or it will be distributed. So, these are the different phenomena associated with the drug following absorption. So, these are the different pharmacokinetic phenomena: absorption, distribution, metabolism, and excretion. What is the basis of drug interaction? As we discussed in the very beginning, the basis of drug interaction can be pharmacokinetic interaction or it can be pharmacodynamic interaction. Pharmacokinetic interaction means when two drugs are given simultaneously, one of the drug will be affecting or it will be interfering in the absorption, distribution, metabolism, and excretion of the other drug. Because of this, the level of the other drug in the systemic circulation at the active site will be changed. So, this may lead to either enhanced effect or this may lower the desirable effect. Similarly, pharmacodynamic interaction happens when two drugs given simultaneously. So, one drug will be either enhancing the affinity of the other drug, it will be antagonizing the effect of the other drug, or it will be adding up to the effect of the other drug. So, this is how pharmacodynamic interaction happens. In these cases also, either the effect of the pharmacodynamic interaction will be more or it will be less. Let us go through some of the examples of pharmacodynamic interactions. So, the first is synergism. Synergism happens when the effect of the effect that is observed because of the two drugs is more than the individual drugs. That means C is greater than A plus B. One example where it has beneficial effect is when we administer aminoglycosides with penicillins. Penicillins are bactericidal through bacterial cellular destruction. They destroy the bacterial cell wall. Because of this, aminoglycosides get into the cell in higher amount. That leads to an enhanced effect which is better than the additive effect of aminoglycosides and penicillins. It may also, this synergism can also have detrimental effect as observed in case of barbiturates and opiates, where it may lead to higher sedation and can lead to respiratory depression and even death. Similarly, summation or additive effect, where the effect is the sum of the effect of drug A and drug B, that is C is equal to A plus B. One example is aspirin and acetaminophen. Acetaminophen does not have anti-inflammatory effect, but it can add up to the antipyretic analgesic effect of the aspirin. It may also lead to detrimental effect. For example, macrolides and quinolones, both antibiotic groups have the potential of inducing heart arrhythmia. Another case of pharmacodynamic interaction is antagonism. Antagonism is that when one drug opposes the effect of the other. So, in that case, if you give A and B, then their resultant effect C will be less than A plus B. One example is your opiates and naloxone. Naloxone as the opioid receptor blocker will reverse the effect of opioid drugs in acute pyogeny, that is so that is why it is used in respiratory depression. Another example is copper and penicillamine. Penicillamine binds copper, and that is why when there is copper poisoning or excess amount of copper, you can administer penicillamine to reduce the harmful effects of the copper. So this is one of the beneficial outcome. There is another example of detrimental effect is when you administer warfarin and vitamin K simultaneously. Let us go through some of the examples of pharmacokinetic interactions. One example is interference in the absorption, where there is decrease in absorption. So acetaminophen and activated charcoal, when given simultaneously, activated charcoal can absorb acetaminophen and thereby prevent its gastrointestinal absorption during an overdose of acetaminophen. So this leads to this prevents the poisoning because of acetaminophen. Similarly, another case of interference in the absorption or decreased absorption which has beneficial effect is lidocaine and epinephrine. Epinephrine does have vasoconstrictive effect, and this slow the systemic absorption of the injected lidocaine if the lidocaine is given simultaneously, and because of this the effect is prolonged for lidocaine is local anesthetic, so the effect of the local anesthesia is prolonged for a period of time. Additionally, this also reduces the systemic toxicity. So these are the beneficial effect we get because of the interference in the absorption or decrease in the absorption. There may be also increase in the absorption, as in case of ketoconazole and Coca-Cola. Coca-Cola, the soft drink you take, it will be reducing the pH of the gastrointestinal content, and this increases the dissolution of ketoconazole, and it can also which can lead to the enhanced availability of ketoconazole, so the effect will be enhanced. There are also examples of harmful outcomes because of the interference in the absorption, as in case of tetracycline, ferrous sulfate, and ketoconazole and antacids. For example, antacids will be raising the pH of the gastrointestinal tract, and because of that, that will be reducing the dissolution of ketoconazole, and it will be preventing it, or it will be reducing the GIT absorption of the ketoconazole. Similarly, the drugs when given simultaneously, they may affect the distribution of each other also. One case is displacement of plasma protein binding. When the drug is taken, it reaches systemic circulation, it will be binding to plasma protein, and majorly the albumins. So one drug may bind to the plasma protein, the other drug may compete for that, and because of that it will be competitive binding, it will be displacing the other drug. One example is your warfarin and sulfonamide. Sulfonamides such as sulfamethoxazole will be displacing warfarin from the plasma protein binding site, and this will be increasing the plasma concentration of the warfarin. Similarly, displacement can also happen from tissue protein sites also, tissue protein binding sites also. One example is your digoxin and quinidine. As in the case of warfarin and sulfonamides, quinidine also can displace digoxin from the tissue bound site, and it can also inhibit its metabolism at the same site, and this can lead to digoxin overdose. Pharmacokinetic drug interaction can be mediated through metabolism. This can happen if one drug is either inducing the metabolic enzymes or it is inhibiting the metabolic enzymes, then it can interfere in the metabolism of the other drug, which may alter the effect of the drug. One case, for example, is bilirubin and phenobarbital. Phenobarbital increase the conjugation and excretions of bilirubin, hence that will be reducing the hyperbilirubinemia in neonates. Another example is warfarin and rifampicin. Rifampicin accelerates the metabolism of warfarin, it enhances the metabolism of warfarin, and because of that it will be reducing the anticoagulant effect of the warfarin. This is the one case of interference where the metabolic enzymes are induced. Another case where metabolic enzymes are inhibited is phenytoin and erythromycin. Erythromycin inhibits the hepatic metabolism of phenytoin, and because of that it will be leading to accumulation of phenytoin in the body, and that may lead to toxicity. Another mode of pharmacokinetic interaction is interference in excretion. Excretion mainly happens through urine. So, any change in pH of the urine or any change in secretions or tubular secretions of the urine may alter the degree of excretion of the drug or the metabolites. For example, aspirin and sodium bicarbonate. Sodium bicarbonate, it's a basic compound, so that will be raising the pH of the urine, and because of that the urine pH will be high, so tubular reabsorption of aspirin will be lowered, and because of that there will be increasing excretions of aspirin. That is why sodium bicarbonate is used while there is overdosing of aspirin. Another example is penicillins and probenacids. Probenecid inhibits the tubular secretions of penicillin, and this leads to reduced excretions of penicillin that prolongs the durations of antibiotic action. Still another example is methotrexate and aspirin. Aspirin inhibits the tubular secretion of methotrexate. This leads to reduced excretions of methotrexate, and that may lead to accumulation of methotrexate in the body, and this may lead to toxicity. Among the pharmacokinetic drug interaction types, metabolism mediated pharmacokinetic drug interaction is more prevalent. This is because many drugs are there which are substrates of different metabolic enzymes, and because of this there is increased competition for the metabolic enzymes when the drugs are administered simultaneously. As you can see here, there are several metabolic enzymes, and there are a lot of drugs are substrates of these enzymes. So, when these drugs are given simultaneously, they will be competing for that particular enzyme, and that may lead to metabolic interaction or leading to pharmacokinetic interaction. In this slide, you can see there are several inducers and several inhibitors. For example, for CYP1A2 enzyme, you see cigarette smoke, phenobarbital, ritonavir, carbamazepine, these are inducers of this enzyme. That means if you are giving these drugs or you are smoking, then this particular enzyme will be overexpressed. Similarly, there are inhibitors of this particular enzyme like enoxacin, ciprofloxacin, fluoxetine, nefazodone, etc. So, these drugs are inhibitors of this particular enzyme. Similarly, for each isozymes of cytochrome P450 or this metabolic enzyme, there are inducers and there are inhibitors. So, if a inducer is given along with a drug, that will be leading to increase in metabolism, and if a inhibitor is given along with the drug, that will be reducing the metabolism or increasing the level of the drug, and this is how metabolic interaction leading to pharmacokinetic interaction can happen. Drug interaction can happen with also herbal drugs. Nowadays many herbs are given as complementary medicine along with this drug, and that is why there are also chances that these herbs may also have drug interaction effects. For example, in India diabetes is very prevalent, so people usually take diabetic or anti-diabetic drugs. Along with that, they have certain habits, or they use complementary medicines like aloe vera, ginseng, ginger, etc. with them. So there are chances that these herbs or this complementary medicine may have drug interaction in people who are taking these medicines. For example, aloe vera, glibenclamide, they have drug interaction, and it has additive effect on blood glucose lowering. That means the glibenclamide effect or the antidiabetic effect will be enhanced. So there will be increase in blood glucose lowering effect. Similarly, ginger also is having drug interaction with glibenclamide and metformin, because this combination with ginger extract will be reducing the blood glucose level greater than the glibenclamide alone. This is a case of drug interaction between Tinospora cordifolia, alcoholic extract, and glibenclamide, which we worked on in previous year, that is in 2018. Tinospora cordifolia is widely used as a complementary medicine because of its effect against diabetes, and people have a habit of using diabetic medication like glibenclamide, and along with also they take Tinospora cordifolia. But what is the implication of this? Whether there is any enhanced effect, or there is any risk associated with, or there is any pharmacokinetic interaction, it was never studied. So we worked on that, and we found that Tinospora cordifolia is having pharmacokinetic interaction with glibenclamide, which we will show in the next slide. As you can see in this slide, the IC50 of Tinospora cordifolia for this CYP2C9 is 0.092 milligram per ml. For CYP2D6 it is 0.170. Similarly, for CYP1A2 it is 1.490, and for CYP2C19 it is 0.866. Thus, the activity of 2D6 and 2C9s are strongly inhibited by this Tinospora cordifolia. So this may have effect on glibenclamide, because glibenclamide is a substrate of this particular enzymes. As you can see in this slide, after observing that Tinospora cordifolia extract has inhibitory effect on different metabolic enzymes for which glibenclamide is a substrate, we tested their simultaneous administration. So we administered Tinospora cordifolia extract along with glibenclamide for 14 days, and we found that in the rat liver microsomes, the metabolism is inhibited for glibenclamide, and this has led to increased availability of glibenclamide. As you can see in this area under curve, when Tinospora cordifolia extract is given at a dose of 100 mg per kg and 400 mg per kg, there is a proportionately increase in the plasma level of glibenclamide. That means when Tinospora cordifolia, because of its ability to inhibit the metabolic enzymes for which this glibenclamide is a substrate, the metabolism of glibenclamide has been reduced. Because the metabolism of glibenclamide has been reduced, there is increased bioavailability of glibenclamide. That means higher amount of glibenclamide is available in the systemic circulation. So this is about pharmacokinetic interaction, and in this class we have discussed pharmacokinetic as well as pharmacodynamic interaction, which will be helpful for students who are following these modern bioanalytical techniques. Thank you.